Well, hi, good evening, everybody, and welcome, or good afternoon, depending on where you are. I'm Natalie Evans. I am a vascular medicine physician at University Hospital's Harrington Heart and Vascular Institute in Cleveland, Ohio. I'm also a member of the PAD Collaborative, which unites organizations and experts committed to advancing the National PAD Action Plan. And this evening, I'm really honored and delighted to kick off and moderate this virtual roundtable. It's in partnership with the Society for Vascular Nursing, the Association for the Advancement of Wound Care, and the PAD Collaborative. And this is PAD Awareness Month, so we're rounding out PAD Awareness Month with this roundtable. We'll spend the next 40 minutes or so talking about PAD, what it is, its treatments, who's at risk, and some of the barriers to care. And we'll follow that with what I hope will be a really lively discussion among our panelists based on your questions to round out the hour. We have a really exciting lineup, including a PAD patient, a nurse who coordinates PAD care, a wound care specialist, and a vascular surgeon who treats PAD. Before we get started, I want to take a moment to share why we are so very passionate about this important topic. PAD is incredibly common. Peripheral artery disease, or what patients might recognize as leg circulation disease. Somewhere north of 8 million people in America have PAD, and that's likely an underestimate. It's probably a lot more than that. And it is a really serious health condition. People with PAD are at high risk of heart attack and stroke, and many patients with PAD actually die from cardiovascular disease events. And of course, one of the most feared complications for patients is leg amputation. There are about 150,000 non-traumatic leg amputations in the US every year, a number that I think we all agree is way too high. Unfortunately, even though PAD is common and can be a severe health threat, the public awareness of PAD remains low. And so, for example, in work done by the American Heart Association, only around a fifth of at-risk people in the US had ever even heard of PAD. Unfortunately, we also know that healthcare provider recognition of PAD is low, and this really creates in my mind, a double jeopardy situation for patients. It leads to longer times to diagnosis and gaps in care. And often, because of those longer times to diagnosis, the first treatment a patient with PAD may be offered is amputation, which from my perspective is just a tragedy. So there's a national PAD or a national amputation epidemic. I'll show you a slide here. So the amputation epidemic really disproportionately affects Black and Hispanic Americans and those in rural areas. And so you can see here that amputation heat map that was created through the PAD Collaborative and it's hosted on the American Heart Association's website, along with other resources, including the PAD Action Plan. And so you can see here the rate of amputations per 100,000 by congressional district. I'm going to introduce our first speaker in a moment, but before I do, I want to let everyone know that if you have questions for our panelists, please put them in the Q&A box, and we'll use those questions to generate our discussion this evening. So without further ado, I want to turn it over to our first speaker, Mr. Frank Diaz from Chicago. I've had the privilege of knowing Frank for a long time through his work on the National PAD Awareness Task Force and as a member of the PAD Collaborative's Patient Advisory Group. He's a long-serving volunteer and former employee of the American Heart Association, and he is a huge patient advocate and helper to other patients. And so, Frank, I want to welcome you, and please tell us about your experience as a PAD patient and what we can learn from you.
Okay, thank you, Natalie, and good afternoon or good evening, everyone. Very pleased to start things off by telling you my story, which started back in 2014, some 7 or 8 years ago. I've been a long-time diabetic, and I thought I knew a lot about diabetes warning signs, such as dizziness if my blood sugar is low, or excessive thirst if my blood sugar is high. But I had no idea that foot drop could also be a warning sign for diabetes. That one escaped me. It so happens I was commuting from work, heading home one day in December, and suddenly my right ankle wouldn't lift my foot off the pedal. And I found myself driving home with my left foot. I don't know if you've ever had a chance to do that. Not a good exercise, but I made it safely. And the very next day, I ran to my doctor and explained that my foot would not respond to my ankle. So I had foot drop right away. He checked my pulse on my foot and noticed a pale color, and he called it right away. He said, "This could be peripheral arterial disease. We got to get you to a vascular specialist right away." So I was fortunate first that it was diagnosed immediately. It was not confused by way of similar symptoms with any other disease. And I got to meet a vascular surgeon who, in due time, gave me an angiogram, and sure enough, found blockages in my arteries behind my knee. Right away, he said, "We're going to do this, and if that doesn't work, we're going to do this." And I kind of fell into a false sense of calm and confidence that he knew what was going on. He had a plan, but it turned out we went from angiogram to fasciotomy to stents to bypass, and in short order, in a matter of 2 years, the call came in. My foot was turning all kinds of colors and looking very swollen, and that meant no blood flow, nothing down below the knee. And so an amputation was in order. So by January of 2017, I submitted my leg and left the hospital with just my left leg. And now I'm the proud owner of artificial right leg, which I take care of now for 7 years. So yeah, I was quite fortunate though, because all throughout those 2 years, I was hospitalized so many times. Unlike other people, I didn't have any insurance issues or obstacles. My insurance covered it all with no letters or phone calls. And I also got very good medical attention at the hospital I attended. And I didn't get to ask a lot of questions. Everything seemed to be running normal, but little did I know that I should have been a little bit more aggressive in understanding peripheral arterial disease and asking questions about treatment, and maybe even a second opinion, which here in Chicago, we have hospitals and medical centers fighting for patients. So I could have had, my choice of second opinions, but it just didn't come across because I was being well attended at the time. But that's really the moral, the lesson to be learned. Number one is to ask a lot of questions and interrogate your medical staff. Whoever comes around doing the 7 a.m. rounds, ask questions. When your physician stops in to visit, ask questions. And likewise, be sure you have an opportunity to say, "Hey, is there another opinion on what's going to happen to my leg or my arm or whichever limb is affected?" And don't be bashful like I was. So that's one takeaway from my experience. Uh, Now I'm busy promoting PAD among lay people and peers. and letting them know, like any other disease, PAD doesn't stop you from living. One of my motivators coming out of the hospital was to play my guitar standing up. I play rhythm guitar in a band, been at it for a number of years, and I usually play standing up, and so that's what I was used to. I didn't want to see myself on stage sitting down, uh, strumming a guitar or singing. So that was the one thing that kept me in physical therapy, about 5 or 6 rounds of therapy over the course of 25 months, home therapy that followed, and all the exercise I could do. So it's important to have something, anything that just keeps you from, sitting around and feeling sorry for yourself. So my thing was, let's make sure I can stand up while I'm playing and have a good time with it. So I just like to tell people, hey, there is life after PAD. So it's not a death sentence at all. And again, luckily, my insurance took care of my artificial leg. So I was able to do therapy with the prosthetic and keep moving and keep going. Thank you.
Thank you, Frank. I really appreciated hearing your story, and I'm sure the rest of the participants did. And I love that you found that kind of motivation to keep going. Um, next, I'd like to welcome Ms. Bernie Ammons. She's a nurse with a wealth of clinical experience for I think about the last year has been working as the clinical program coordinator for UVA Health in Charlottesville, Virginia, to help patients with PAD access care. Bernie, thank you so much for being here. We'd love to hear more about how you deliver vascular care in Virginia.
Thank you for that warm introduction. And in Virginia, we have several areas that have dense populations. And so Charlottesville, where we're at, is a college town, and UVA is a large academic medical center, a level 1 trauma center. And we're fortunate to have a lot of clinical expertise in interventional radiology, vascular medicine, vascular surgery, podiatry, and all the other multidisciplinary care providers for patients with peripheral arterial disease. But when you get outside 25, 30 miles from Charlottesville, there are a lot of pockets of rural areas. So one of the things that UVA Health is really doing is providing access to care in different satellite hospitals. We have expertise available in cities like Waynesboro and Culpeper. And we have another site in Prince William at the medical center there. We are providing care through using mobile buses and the use of telehealth services to reach people who might have to travel distances for any of their care, but particularly with peripheral arterial disease. So that being said, the way that our care delivery model is given in the clinic is patients will come in, they will be given a questionnaire to look at their social determinants of health. And then they come into the clinic and are screened even further by medical assistants. And then they see our RN care coordinators who do further investigation into the different social determinants of health. And our advanced practice providers will see the patient, do education. They're getting touch points by many different specialties, but also reiterating the same information and education. And then once the APP sees the patient, the physician or vascular surgeon will come in and talk with the patient about their studies and review their studies and make a treatment plan. If, for example, they need surgical intervention, sort of what Frank was talking about, we have a nurse navigator who will help take the patient through the continuum of care, and they evaluate all the different elements of the social determinants of health to make sure the patient has a holistic approach to their care. And there are many experts here at UVA, which I think allows for us to be able to use the different resources we have to address some of these needs. We have the ability to do care conferences too, to make a treatment plan for a patient. Other things that we're doing here with UVA and in the state of Virginia is for those people who can't transport or be here in person, or if they don't have access to the internet, we're setting up the use of libraries for patients to be able to access the internet. And we have a hospital at home program. So the other platform we're using or starting to use is something called Unite Virginia, where we will be able to access many different resources for patients that address. And as you can see here on this wheel, this is actually a picture or an image of the wheel that is seen in EPIC, which is the electronic medical record that we use here. And you'll see that part of the social determinants of health that are looked at are tobacco use. We have the ability to put referrals into, we have a smoking cessation specialist here. And that's a big thing for people with peripheral arterial disease, is to help them with quitting smoking. We have the ability to generate or look at whether they have financial resource strains, transportation needs, issues with stress, intimate partner violence, housing stability, if there's substance abuse, or any issues with food insecurity. This also allows us to look at physical activity, social connections, if they have a depression scale that can be utilized, and also looking at utilities, whether they have electricity, running water, that type of thing. So by filling out this screening tool, it helps to generate referrals directly to the social worker or case managers who help with the care for the patients with PAD. So it's a work in progress, but we have more resources here and are connecting out into the rural areas by using some of these innovative resources with telehealth and working with population health to reach patients that can't physically get here all the time.
Thank you so much, Bernie. It sounds like you're really making terrific efforts there at UVA to get care to people who historically may have had some challenges with access. And I love this use of this social determinants of health. And I'm excited for my health system, which is new to EPIC, to get that going. I'd like next to turn it over to Mr. Monty Douglas. He's a physician assistant who specializes in wound care, and he's passionate about wound care. And we know that foot and leg wounds can be one of the most devastating consequences of PAD, and for some people can lead to amputation. So Monty, talk to us about your approach to wounds in the setting of PAD.
Yes, thank you, Natalie. So majority of the time, the patients are referred to me from the PCP. Now, what ends up happening is that the patient comes in, they saw their PCP, and they end up having wounds on the leg, the feet. No diagnostic workup was even initiated at that visit. I do spend a great deal of time with my patients. When I start going through their risk factors, how long the wound's been there, what makes it better, what makes it worse, that history is so important in interviewing or getting that history. Now, at that time, once I recognize that, hey, we've got a vascular problem, we're on a time crunch. The very first thing is I've got to get that patient to a vascular surgeon. Now, where I'm at, I'm in a rural area in Arkansas. It's just me and one nurse. And managing a patient with PAD and non-healing wounds is incredibly complex and very, very difficult, especially behind the scenes of what needs to happen. It took a lot of work networking with out-of-town surgeons that could help me with my patients. Here's the deal, and the truth is that the longer we wait with PAD and non-healing ulcers, the greater the risk of amputations. And I go by this term that time is tissue, and I don't wait around. It's day one. We have got to get a diagnostic workup and get you to a surgeon quickly. And a lot of times I'll just do a bedside ABI with a blood pressure cuff and just kind of get general numbers, and I'm picking up the phone and calling. In fact, I had a patient today that was sent to me with critical limb ischemia. And I'm just like, it blows my mind that the awareness of a lot of providers, this is not caught before they get to wound care. And as a team, everybody must do their part and follow the patient. Now, this is not the typical managing a patient with PAD where we just check box medicine. I mean, every patient is unique. Every patient is different. Every wound is different. Time is a limited resource. It is the greatest gift we have on this earth is the time. And so establishing that network and that connection and getting these patients to heal, especially after revascularization takes place. The things I worry about the most is the microvessels, after a patient is revascularized. And a lot of times post-operatively, I'm still following the patient on a weekly basis, managing that wound. And our goal, time to heal, is about 10 to 12 weeks, because I immediately go into limb salvation mode when I see wounds. Now, a general rule of thumb that I go by is if you've got non-healing chronic ulcers, feet, legs, toes, we need prompt vascular workup day one. Don't wait around. Trying to meet with all of our residents and PCPs here and having them aware to go ahead and start that workup now and go ahead and make the referral to vascular and wound care. You could, and I tell them, you could save a limb or a foot, a toe. It's that important. And this can affect patients' quality of lives, because before I got here, we were known as the preoperative amputation clinic. And we had brochures on our counter of which prosthesis you could get. And that was very, very difficult. I threw all of them away. I said, we're going to start saving people's limbs, and we're going to move forward and get patients healed. And so it takes a great amount of effort, great amount of teamwork, continuity of care, of getting patients, managing the patient care behind the scenes and where we need to go, and communicating with the other providers as they're going through this process. So thank you, Natalie. Thank
you, Monty. I think our new mantra is going to be time is tissue. So important. And I really hope we can talk more about this in the Q&A session. All right, so finally, I would like to introduce Dr. Catherine Riegstad. She's a vascular surgeon at CentraCare in Wilmar, Minnesota. Dr. Riegstad has some really special insights into taking care of PAD patients in rural areas. So Dr. Riegstad, talk to us about what people should know about treatment of PAD.
Oh, thank you very much for that introduction, Dr. Evans. So yeah, as you mentioned, so I practice in a rural community in Minnesota, town of about 20,000 people. We have patients that travel up to an hour and a half away, and we are blessed to have a tertiary referral center a couple hours away and another about an hour away from us. So we do have some support. We're not totally out there, but definitely there are some challenges. So first of all, of course, being a surgeon, I like surgery. So I just thought I would go through some of the most common procedures that we do. It's very helpful just to have an understanding of what it is. I think oftentimes patients are intimidated by surgery, but it is it's a straightforward thing. It's kind of like plumbing. You're just opening up a blood vessel and getting blood flow to where it needs to be. So 3 basic types of vascular procedures are open, endovascular, and hybrid. So open involves actually making a cut directly over the artery. Typically, you're either doing an endorectomy, which is where you clamp the artery, of course, so it doesn't bleed, make a cut along the artery, clean out the plaque, scrape it out, and then put a patch on it. Tell patients that patch is almost always made out of cow heart, so we part cow afterwards. So people always joke that they're going to moo afterwards, but I've not had that issue happen. So yeah, but probably most common open procedure is endorectomy, and then bypass is also a very common procedure, and that involves taking some type of graft, either the patient's own vein, if there's infection, cadaver vein, or a prosthetic bypass, and sewing one end of that graft to a healthy artery, and then tunneling that graft through the patient's own tissue to a separate incision where there is a healthy artery that opens up below the blockage, and then essentially just like a road bypass, bypassing that blockage and then getting healthy blood flow. So those are the 2 most common type of open procedures that I do. And next big category is endovascular, and that's a area that has made huge advances. It first became a thing in the 1970s, but even since I finished fellowship 8 years ago, there's just been a lot of advances in different techniques, whereas the open procedures have pretty much stayed the same for the last few decades. So endovascular, that involves, generally it's a puncture either through the femoral artery at the groin or the brachial artery at the elbow, or in some cases at the wrist. And then really from that location, you get to anywhere else in the body. And then taking a picture of the artery, getting across the narrowing or blockage with a wire. And then from there, you really can do whatever treatment is appropriate given the situation. So that could simply be stretching it open with a balloon, using a balloon with a special medication on it that keeps the plaque from coming back as quickly in the future. Placing a stent graft. I have one here. I don't know if people can see it, but that's a stent that's covered. It's very flexible, you can see, so it's can really conform to a lot of anatomy. And that too, there have been advances in recently. And lithotripsy is another very helpful tool that can help break apart heavily calcified plaque. And so it really varies depending on the type of plaque patient has. Atherectomy, which involves removing the plaque. So just a lot of options, and it's, in one sense, it's very nice to have these options. We're able to save a lot of legs and help a lot of people that we previously weren't able to. But on the other hand, it can be difficult to keep up with all these options, even as a provider, but especially as a patient if you're trying to navigate these waters. Then the final main technique that we use is hybrid revascularization, and that involves, as the name implies, both open and endovascular techniques. So most common one I do would be a cut along the groin, getting into the femoral artery, which is the main artery at that location, cleaning out the plaque. So that's the open procedure. And then placing a stent graft in one of the pelvis arteries to open up the blood flow. Oftentimes these patients have multiple levels of blockages, and you may treat one level, you may treat 2, you may treat all of them. It really, again, depends on the situation. So that's really pretty much all vascular procedures can be classified into one of those 3 categories. And then really even more important than the type of procedure that you do is going to be why you're doing the procedure. You certainly don't, if there's a blockage, that doesn't mean that you fix it. You need to really think of why you're doing what you're doing. Very clear-cut examples, as Monty had discussed, would be a non-healing wound that is the main source of it is poor blood flow. Another one would be if a patient has severe leg pain with walking that's determined to be from a blood vessel blockage. That's a pretty clear-cut indication in most situations. And then final one would be pain at the foot that's determined to be from blood flow. If any of those are present, either a wound or pain at rest at the foot, that it is classified as limb-threatening ischemia, so they are in danger of losing their leg if you don't do anything. On the kind of flip side of that, reasons not to revascularize, one would be pain with walking, so leg muscle pain with walking. If it's severe, should revascularize that, but if it's not severe, if somebody can live with it, or if there are other factors, such as if somebody's still smoking, that does definitely decrease the longevity of any procedure. So if any of those are present, that would definitely give me pause. Also, there are some medical managements for that as well, and also certainly lifestyle with walking. Other situations would be if there's a non-healing wound that has some other significant contributing factors that are not arterial related. Particularly if it will be a complex procedure to do, or if the patient is very frail, then you might also say, oh, let's maximize wound care, maximize these other options and see how somebody does. One final one can be a patient who does not walk. And this is always surprising to patients, but if somebody does have, if they are, say, bedbound, nursing home patient and do not walk at all, the recommendation in that case is actually to proceed directly to amputation above the knee. So that you really need to have a discussion with patients about, and the reason for that is that the patient will not gain any functional improvement from saving that leg, whereas you, on the other side, if you try to save the leg, you're subjecting them to all the risks of revascularization, and oftentimes these can be quite difficult procedures. That being said, in reality, in my practice, oftentimes I have certainly done procedures for limb salvage in patients who do not walk. Generally, if it's a more straightforward procedure, but you just really want to give a good discussion with them about what expectations they should have. A couple other issues too, just unique to a rural environment. I think Frank, you mentioned patients or the surgeons fighting for patients. That is definitely not the case here. We would like to have more providers than we have, and so just even gaining access to care, not only seeing the vascular surgeon, but even if I see a patient with critical limb ischemia, it can be difficult to get them scheduled for a procedure simply because we don't have enough interventional radiology techs, we don't have enough nurses. That can be a difficult aspect too. And so we really do what we can with rescheduling patients that are less urgent, but certainly can be a difficulty. One important factor I think is just family engagement and caregiver engagement. Many of the patients that I see really are not able to advocate for themselves simply because they are extremely frail, might be older, have some dementia, and so they really are not able to advocate for themselves. So having that family there and patients there during the visit is just extremely helpful. It's really encouraging for me, even as a provider, to see some of these family members who are there like every visit, and it's tough for them to get there, but it's very helpful to see that, and definitely helpful for the patient too, just being able to give that additional history that the patient may not be able to provide for him or herself. Other ways that patients, family members or caregivers can advocate for them, if they're not able to make it to appointments, either due to work commitments or other commitments, even calling in, that's helpful to have somebody else on the line, helpful for me to have that history and just to really have a plan of care in place. Another one can be simply trying to keep care in the same healthcare system if possible. Now, this is sometimes easier said than done, but I think sometimes patients are under this illusion that I, as a provider, automatically see any study that was done in any healthcare system whatsoever. And unfortunately, it's not the reality. I only see the studies that were done in my own system, which is Centricare in my case, and really for any other provider, that's really the same thing. You can get those images or reports transferred over, but it can take some time. We've had patients from out of state, and it can take a month to get imaging to get the actual images to look at. So it can be some delay in care. So ideally keep it in the same system if it's possible. And then simply being aware of patients' conditions, if they have any difficulties with medications, food, exercise, any other help that they need, being aware of those problems can be very helpful as a caregiver. And then finally, really participating in events like this, having a basic understanding of what the condition is that your family member has. And we always kind of joke about looking up stuff on the internet, but the internet does have a wealth of resources. So for example, Mayo Clinic has good websites and articles about peripheral arterial disease or other conditions that they may be facing. So just having some basic understanding of what's going on, that's very helpful too as a caregiver. And so thank you.
Thank you so much, Dr. Rigstad, for really, I think, super helpful and comprehensive kind of discussion about what patients with PAD can expect. And I want to thank all of our participants, and I'd like to open it up to the Q&A. If you have questions, type them in that Q&A box. I'm going to start off with a question for Bernie from the chat. Someone asks, what are the different things your nurse navigator does? It's a new role we have developed at my vascular clinic, and we are still navigating the position.
great question. Cindy Kennedy is our nurse navigator here at UVA Health. She has a wealth of experience with vascular surgery patients and the complexity of those. But when I was describing when a patient comes in the clinic, let's say that they are coming in for a visit and they decide that they do need to do an amputation, or they need to talk about another procedure for a patient with PAD and they're having a surgical intervention. Cindy will sit down with the patient and their family member and do a complete review of their chart, make sure they have all of their pre-op testing and labs and images that they need. She will do teaching about the procedure that the patient is going to have and offers them the ability to ask questions. So the patient gets numerous opportunities to get education about the procedure they're going to have. She will do teaching preoperatively. She will see them before they go home. She will follow up with them 2 to 7 days with a circle back call is what we call it. Sometimes she'll use telehealth services if a patient's in a skilled nursing facility or a rehab facility to check and make sure, do the nurses or the patients have any questions about their medication or post-op care, or how is their surgical site looking, and that type of thing. And that we have found through research can help to reduce our readmission rates. Cindy also does, in collaboration with me and our nurse manager and our director and other care providers for the vascular surgery patients, we look at our quality support team meeting to review data and see what can we do better. She helps to create education for the different procedures, and we update those as needed. She does a wealth of many different things. And it really is helpful for the patient because they have that one continuous person that sees what they've gone through from the beginning until the end of the process. I hope that answers the question. If anybody has anything else, let me know.
Thank you so much, Bernie. It sounds like that longitudinal relationship with the nurse navigator is so important. So I have a question. I'm gonna try to pronounce Dr. Tad's name. I think it's Piershanowski, and you can tell me in the chat how I did. He wants to know, Frank, after you presented, were you referred by your doctors for a cardiac assessment?
Yes, actually, I submitted, I went under for a couple of CT scans, I believe. Again, 7 years ago, so my memory may fail me, but I do recall that my cardio was pronounced okay, was declared fine, and not in danger or affected by what was going on with my leg. So I believe the CT scans took care of that. Thank you for asking.
And I'll build on that question, and maybe for some of our clinical folks. So why might a cardiology assessment be important for a patient who's been diagnosed with PAD? And maybe I'll open that up to Dr. Rigstad.
Yeah, I guess, yeah, no, thank you. So as I think we mentioned earlier, that if you have blood vessel disease in the peripheral arteries, it's somewhat assumed that you have it in the coronary arteries and even the cerebral arteries. So that's part of the reason that we do recommend aspirin and statin in all patients. The statin is not so much to help open up the arteries, but more so to help prevent heart attack and stroke, and same with the aspirin. And yeah, in general, in my practice and my partners, if we are doing something for more urgent critical limb ischemia, or if it's going to be a more an angiogram or a procedure that does not have as much anesthesia risk, then we would not routinely refer for cardiac assessment as long as the patient's primary care provider has no specific concerns. And just because oftentimes the revascularization is much more urgent. Whereas definitely if they have any symptoms or any risk factors, and or if it's going to be a much more involved procedure, such as something involving cross-clamping the aorta, much higher risk, then we would typically refer for that. Yeah, good question though.
Yes. I do recall my primary care physician was very concerned that what was going on with my initial diagnosis may have had something to do with my heart. This was when I first presented symptoms, and he literally walked me out of the medical office building across campus to the main hospital to find a vascular specialist. So in that regard, I understood the danger of a blockage in my leg having something to do with my heart.
Yeah. And also, and you didn't have any pre-existing heart conditions that you knew of at the time, correct?
No, my late father, had a history of heart problems, but at the time this happened, I was okay, cardio-wise. Yes.
Frank, I want to follow up on that. You had a terrific primary doctor. Your primary doctor was right on top of things. And we know, unfortunately, that that's not always the case for people just because, unfortunately, healthcare provider awareness is still not optimal. What advice do you have as a patient for people who might not have that same kind of situation where their doctor's really on top of things?
Well, again, a certain measure of aggressiveness has to come on the side of the patient when they figure out what their symptoms might be. And as they explain symptoms to the doctor, there has to be a moment where the patient might know just a little bit and may suggest to the doctor that it could be PAD. Nowadays, we run to Dr. Google and find out all kinds of information, and we think we're armed with details that might help us when we present. And so that could be the bright side of doing some internet research. We know there's another side to it, but at least a patient can come in and say, it could be this or it could be that. And if you sense a professional isn't quite sure or hesitates, that's the opportunity to say, maybe it's PAD. Please check my legs or check my arms. Is there a test or something you can do? So I as a peer, I put it on other patients to speak up at the right time.
Yeah, thanks for that, Frank. Kind of building on this even further, so there's a question in the chat from Dr. David Perez Barreño to everyone. We'll open it up to everyone. He's the president of the Spanish Association of Vascular Nursing and Wound. And he says that they often find that the main problem is that the patient is unable to identify the signs of PAD, so they don't seek out care. And when they do, it's already too late. How does our group think the awareness and visibility of PAD in the population could be improved?
If I might speak a little bit about that, one of the things that I'm engaged with is working with community outreach at UVA Health. We also have a group of physicians who work with the Latino Health Initiative. So, for example, a couple weekends ago, we went to a health fair in one of the rural communities and set up cardiovascular screening, A1Cs, lipid profiles, and we had physicians there who could speak Spanish for those people. It's a safe environment when you come to some of these fun family health fairs. We set up a table to talk about peripheral artery disease as well. And no one that came to visit our table knew what it was. So I think reaching out to church communities and health fairs, that's one way I believe we can reach out to, in this case, specifically the Spanish population.
Thanks,
Yes,
Frank.
I got to do a lot of similar work in health fairs and outreach efforts when I spent a couple of years with the American Heart Association. And I'm eager to return to the health fair circuit here so I can make a PAD the topic of conversation in that setting. I think it's very valuable, especially if ABI or ankle brachial index tests may be available at a health fair in a parking lot somewhere.
I think on the, on the provider
Ed,
end of this.
sorry.
Oh, sorry. So, no, just one quick comment on the provider end of the spectrum. Just one thing that you got a very small thing is just try to message back physicians who refer patients, either like if they think it's PAD and it's not, just let them know, thanks for referring them, but it's not this for whatever reason. And if it is PAD, just say like, yes, that was the correct thing, and just giving them some feedback, because I think they're extremely busy too, and I think pulled in many different directions and having to see so many patients, and so they have a lot of yes, different competing factors, and so just trying to give them some feedback on yeah, what's going on and what my perspective is, and what I've seen in the patient that they referred. So that's, I think, it'd be helpful for building some awareness on their part.
Yeah, and I think just to emphasize that point, it's the relationships that you build with the people who refer to you are so important, because they will start to see it more. A couple of people have asked in the chat about compression for PAD, and I wonder if some of our clinicians could answer that question.
Does anybody else want to answer it, or?
Hey, I'm Monty.
Yeah, you go on.
Yeah, okay, all right.
Yeah.
A lot of times what I don't just get one solitary single ulcer or wound on the leg. A lot of times I see peripheral vascular disease with a mix of venous stasis, venous hypertension, and possibly PAD based on the wound morphology. I also look at the edema associated with it, because patients with PAD can have edema. So what I do is at that time, we're going to start vascular diagnostic workup, get them to a vascular surgeon quickly to help us figure out which one is which. This ulcer could be venous related. This ulcer over here could be arterial related. So at that time, what I do is I look at our ABIs, and then I typically start a patient on a light compression, no more than 20 millimeters mercury of pressure, because patients will respond to some compression. Now, if we're dealing with strictly straightforward arterial disease, at that time, I don't initiate compression until I know it's safe, that we have venous, we've ruled out PAD, and I can initiate a much more aggressive compression therapy. But I like the opinion of our vascular surgeon. Is it safe to start compressing at that 40 millimeters mercury of pressure? When can I initiate that? But typically on day one, to cover a large spectrum of wounds, I will initiate a multi-layer compression at no more than 20. And I typically go with like a Coflex Light. I haven't had any complications from that or cause worsening ischemia at that point when I'm dealing with mixed disease. And I can start seeing some, on a weekly basis, I can actually start seeing quite a bit of improvement with that compression, even with some low grade to moderate PAD, and they still need revascularized or stented or an artery that needs cleared out. But yeah, I want them walking out with something. Now, if we've got critical ischemia, we got rest pain, we've got this pain, I'm not doing any compression. I'm getting to a vascular surgeon, getting to the hospital, calling the vascular surgeon immediately, letting them know what's happening. So that's how I approach it, based on just a screening test with ABIs and initiating that compression. So would anybody else like to add to that? Because I think that's a great question. When is it safe to compress? When is it not to compress?
I'm going to jump in as the moderator. I think the dogma has always been that if someone has PAD, compression is contraindicated, and I don't think that's true. And I agree with you. And a lot of people have difficulty healing their arterial wounds when they're super edematous, and you're further compromising your microvascular circulation. And so I think really judicious use of compression can be helpful. Also, I very seldom put anyone in something as strong as 40 millimeters ever. I'm primarily putting people in stockings, so no one can ever get that on. Now it's different for you guys in wound care, right? Because you're wrapping.
I think, yeah, I totally agree with what you said, Dr. Evans, and you, Monty, with one situation that I have run into, this is more at the nursing homes, is somebody came in with rest pain from critical limb ischemia and had some dependent rubor, so the foot was a little bit swollen and red. And if somebody gets to that amount of poor blood flow, they're gonna wanna hang their leg off the side of the bed when they're sleeping. It needs to be in a dependent position because that will maximize the blood flow just based on gravity. And this particular patient, they're putting it was a light compression, but then also recommending that she elevate her leg to decrease the swelling, and it caused horrible pain for her, and it was exactly the opposite of what she should be doing. So kind of one rule of thumb is obviously checking the blood flow, but in general, if something hurts the patient a lot, probably not the right thing. Now, that's not sometimes people with bad swelling do complain about compression, but if somebody is in horrible pain from it, you're not doing the right thing. And this was, again, it was from people who were unfortunately weren't able to didn't have the experience that the people on this panel do. But I would agree that in general, light compression can be very helpful for some of these mixed ulcers.
So another question from the chat. What are the impediments to annual PAD assessment for patients over 65, which the AHA recommends? And is ABI feasible in the primary care setting? And Monty, I know you mentioned you do an ABI because you have to, you need that information. Thoughts about the primary care setting?
I think it's a great screening tool. Here's the deal. If we're concerned about vascular blood flow, PAD, I've read too many primary care provider notes. We'll consider ABI/TBI, and we're going to refer to wound care. Order it, get it done, or do it yourself. Just do a quick bedside screening. Just throw a blood pressure cuff on the ankle, get the systolic, and we keep a Doppler machine. I can listen. I can get those really, really quick. Takes me a couple minutes. If I need a screening real quick, if I'm concerned, I'm going to get it. And I'm going to get that patient to the vascular surgeon anyway, because it's a screening. It's not always 100% proof to me. And trying to listen for monophasic, biphasic, triphasic, I'm not good enough and skilled enough to say, oh, we're fine, we don't need to move forward. No. I need to be aggressive and get that patient to the surgeon who knows what the next steps are, because I am concerned for these wounds. And really, it's that higher level of care for our patient, because the reality is our patients that come in, they've been living with a wound it's a chronic non-healing wound. They think, oh, I just need some antibiotic ointment or the right snake oil to put on this, and not treating the underlying problem, because wounds are almost always secondary to the primary problem. And we have to treat the underlying problem, else nothing is going to change or heal, and a pill won't fix it. We live in a society in medicine that, hey, we got hypertension, here's a pill. We got diabetes, here's a pill. A pill won't fix this. It is going to require diagnostic workup and a multidisciplinary approach to get you better. And that's the way I approach it, is just taking it to that next level for the patient and making them and helping them become aware of what is happening and the potential risk down the road. And so if that requires me to spend that extra 3 minutes just to get a real quick screening and a Doppler on the foot because I'm concerned and what my next steps are, then I'm going to do it, the next right thing, because half measures in wound care won't cut it. It just won't. I have to go all in to get these patients moving forward and get better. So hopefully that answers the question.
I think it's actually really hard to do in the primary care setting, because I think a lot of us are well, I'm not in primary care, but a lot of us are not good at taking blood pressure. I think it takes a lot of practice to get fast with an ABI. That's one of the issues. I wonder if really quickly in like 1 or 2 minutes, Bernie, could you comment? You mentioned telehealth. Actually, I've heard telehealth mentioned a couple times, and one of the issues that patients in rural areas can deal with is lack of access to internet. And how do we, what do you do in those situations?
Well, I'm not an expert on the particular program, but I do know that they are trying to find libraries that will provide internet access for patients. And that's another program I'm trying to look into to get more information. And then with us joining something called Unite Us platform, we're hoping to be able to have a better way of finding out what patients need. Regardless, food insecurities, transportation, all those things that people need to live. So I think telehealth will be a really great tool, and it is a great tool to help with things like that.
Yeah, thank you. I want to wrap things up. I am so grateful to our panelists for their expertise and input today. And I'm really sad we didn't have another hour to get through all the questions that people have posted in the chat and the Q&A. And I'm just really excited about the level of participation we had tonight. And I also want to thank our collaborating organizations and the people behind the scenes who you don't know, but who have worked so hard on this content today. And so thank you everyone so much. And I think in the interest of time, we'll let everybody go so that we don't go over our hour. This webinar will be has been recorded and will live in posterity somewhere if you want to check it out again. And thank you everyone so very much. I hope you have a wonderful night.
Thank you.